Boomer Life, lifestyle discussion designed to make your life more engaging, meaningful, and complete. Celebrating the baby boomer generation, this is Boomer Life on CIL 650.
Well, good evening and welcome to Boomer Life here on CIL 650. It's a pleasure to have you along with us as we are going to focus on the brain. And, well, we're going to talk about migraines, among other things. Our guests are Philippe Souvestre and Sonia Dheil from NeuroKinetics Clinic in Vancouver. Philippe and Sonia, nice to see you again. Thanks for coming in.
Nice to see you as well.
It's a pleasure.
All smiling and happy and upbeat. This is a tough topic we're about to take on here, Dr. Philippe. But, you know, I think at NeuroKinetics, one of the things that you do, treating people who are severely injured, in a lot of cases brain injuries, is to try to promote an attitude of wellness and positivism. Some of these people come to the clinic and they've been around the block a few times. They've seen medical specialists and practitioners of every stripe and type. And they come to you going, nobody is able to help. What can you do? And in many, many cases, you're able to provide that extra measure of assistance and competence that they couldn't find anywhere else. And a lot of that is attitude, in addition to knowledge and information, isn't it?
It is.
So talk to us a little bit about yourself and how you become such a positive guy dealing with people who are as severely injured as they are and being able to help as many of them as you do.
Well, that ties with a number of experiences I have as a person as well. A part of my training has encompassed reconstructive surgery, and this is a place where you see people coming as no longer as a whole, but rather a collection of pieces and bits. Forgive me the visual picture here, but it is quite a distressing scene. And the mission is to bring those quotes, pieces and bits all together back to the whole person and bring that person back to his or her life and love and passions and you name it.
Sure.
Activities. Yeah.
And this is this whole process of recovery. That we're kind of an instant gratification bunch, we North Americans, and we tend to want everything, Sonia, kind of nicely packaged up and done up so we can get on with our lives in, maybe 15, 20-minute bites. When someone comes to NeuroKinetics, they're in pretty tough shape. And I would think not a lot of them expect to be fixed, if you pardon the word, in a day or two.
Yes.
They understand, having been through negative encounters with the medical community time and time again, they've already built up a tolerance for time and the fact that it's going to take time to get better.
Yes, because if they've seen it, if they've gone through it, by the time they do get to us, just the sense of relief that someone can help them sometimes is just is overwhelming still for them.
Sure.
And hearing, yes, of course, they realize, going back to the question, 1 or 2 days, yes, they're not going to get completely back to the pieces back together again, but
sure.
It does take time. But yes, there is a lot of feeling of overwhelmness.
I'm sure. Philippe, you wanted to add something here?
I would like to add a little comment here. Yes, thank you, Sonia, for sharing that. On the top of that, they are very disoriented. The reason is they have been told and told again that nothing could help them. As far as the scope of competency they have experienced, they have been seeking and given. They have been told about management.
Right.
This is a mindset.
You have a painful condition. The best we can teach you, or the best we can do for you, is help you manage your pain.
Correct.
And this is something it's like a life sentence when you say something like that, isn't it?
Well, it is a label. You are flagged as managed, and no longer flagged as a potential for resolution.
Right.
This is a big glitch and a big gap in the thinking.
Right.
In the way to be and the way to see life from now on.
Because if you're managed, then you're essentially parked. Okay, that file is handled now. We've got that person on medication. It's not going to get much better, but it's managed. Next, and that's it, right?
And there is a negative side of that, of this, is there is no longer an openness to accept new things.
Right.
and there's a fear setting in about anything that would be outside of this management scope of approach, which is really, really a distress and create distress.
Right. That's a pretty typical sort of method of thinking for Western medicine, isn't it? Though you have a condition, we'll match you with some pharmaceutical, some biochemical remedy, and you're parked, you're managed. Next, and you're a Western trained physician. You were a flight surgeon in the French Air Force, for goodness sake. You're a Western doctor. But since moving from France to North America, your eyes have literally been opened, and so has your thinking. And so you're able to apply not only the lessons of Western medicine to neurokinetics, but also you have a much bigger picture approach to well-being. Tell us about that.
Well, it comes from blending different medical cultures and medical point of view models, such as the Oriental medical model,
right,
which includes acupuncture, tuina, and other disciplines that relies on the representation of energetic channels called, the meridians, and the acupoint activities, etc., which now are found actually to relate to very tangible anatomical entities such as the fascia, etc. So Western medical research has come over the past 7-8 years to substantiate these Oriental medical models.
Oh, interesting.
And bridge that gap between the Western medical thinking outside of this new knowledge,
right,
and Oriental medical thinking.
It must be interesting and probably kind of fascinating for you too, particularly because you chose Vancouver in British Columbia to move to from Europe, which of course in North America is as close as you can get to Asia and that whole mindset. And to watch Western medicine in Canada, particularly here where you've been for so long now, evolve, Philippe, to include at least an awareness of other possibilities, and in some cases a realization that maybe Western medicine doesn't have all the answers after all.
It doesn't. And I should say none of those medical thinking anywhere encompasses the answers for everything either.
Right. No individual model is capable of answering all the questions. No. So it's the ability to combine multiple models to find the right answer.
Exactly.
Okay.
And that's what I've been passionate about over the past 3 decades. Yeah.
Right. Now, we're going to talk in the program today about migraines. And so before we get any further into the discussion, I think it's appropriate, Dr. Philippe, to just stop cold and say, what is a migraine? We all think we know, but how about the doctor tell us what a migraine is?
Well, in short, a migraine is a headache. It is typically half of the head, whether the left or the right side, which is afflicted by an intractable pulsating pain, which may occur from nowhere, apparently, or it may be triggered by an excess of light, fatigue, stress, inappropriate visual correction, or extra noise, you name it. It could be anything that can trigger an accident, a diet accident, I would name this on that way, could trigger a migraine in some persons.
Okay, and what age do people typically begin to get migraines? Do children get migraines, Dr. Philippe, or is it mostly a young adult or even full adult condition?
Okay, I have a 2-tier answer to this question.
All right.
Because I have the Old Testament and I have the New Testament. The Old Testament, which I have learned in medical school, says there is no migraine observed in kids, and that will appear at the earliest pre-puberty, dominant then in boys or over the girls.
Okay.
While later on, few years later, let's say 5 to 7 years later, the stats will be reverted, and 2/3 of these migraines will be afflicting women, and the 1/3 only afflicting men, statistically. It has been my experience through time to see that migraine could be seen and understood and treated as such in kids.
Okay.
Absolutely. Yeah.
Okay, so it
has been an evolution.
Okay,
yeah.
It does happen, but it sounds like it's not terribly commonplace.
Well, it's a matter of mindset.
Okay.
it is a matter of mindset and setting the boundaries of the diagnosis, referring to only, I would say, the biochemistry and the clinical, the accepted, the clinical picture of what is a migraine in an individual.
Okay, so I think what I'm trying to get at, Dr. Philippe, is a migraine in and of itself a condition, or is it a clue towards an even more serious condition?
It is both.
Oh, okay.
The reality is it is both. And a migraine per se is never isolated. There are signs involved in the diagnosis of migraines which do not relate to the cranial phenomenon that is typically calling the name of migraine.
Okay.
There are other signs associated with this. They are attached to the diagnosis of migraine in what I have learned in medical school 30 years ago. But recent research and my own observation, clinical observation, has showed me that there is much more than that, and you have different brain controls are involved, for example, in a genesis of a migraine, a typical migraine picture, and it is always observed since I have been aware of this connection.
Mm-hmm.
Yeah.
So a migraine is, first and foremost, an extremely debilitating headache.
It can be extremely incapacitating.
Right.
Yes, and sometimes for days.
Exactly. Well,
Yeah.
I was talking to Sonia about this just before we started it, because Sonia, of course, as the clinic manager, you answer a lot of phone calls from a lot of people who are just calling up, going, "Please, will you listen to my story?" Nobody else seems to want to. So when people call up and talk to you about migraines, I'm just looking at the stats that Philippe was talking about, because it sounds like more women than men are susceptible to migraines. Is that a fairly accurate generalization?
Yes.
Okay.
More so women, but that doesn't exclude the men. There
No.
are lots of men as well.
Oh, I understand
Yes,
that part, but it's slightly skewed more female
Yes.
in terms of those likely to get it. And at what age do people? Philippe was just talking about there are some instances where migraines occur in children, but typically, you also mentioned statistically, they start measuring them in the the puberty years, sort of
Yes.
12 to 14.
Yes.
That's when you start to see people.
Yes.
I have a friend who has migraines, and when she gets them, there are two rules: no noise and no people. She goes away, puts herself in the dark room, Philippe, no sound, no light, and above all, no people. Don't knock on my door. Don't talk to me. Don't ask me how I am. I'm terrible. When I feel better, I'll show up. Is this pretty typical, or is that an extreme example?
Well, it is rather an extreme example, but it's pretty common. Yeah.
Right. And why is there the need for such solitude with the black visuals and no sound? Does that help the condition?
Yes, it does. We know now that migraines rely on a sensory cognitive disorder, to be a little bit technical here, and the cognition ties with processing. Comparing the brain to a computer, you will have a software that animates the hardware. Well, let's referring to the migraine in a human body, we have gifted with a software called the cognition and the cognitive processing, which also underlie the cognitive perceptuality. Forgive the technicalities here, but
right.
I think it's an important word enough to share and to share with the public. And perceptuality covers everything we sense. So we know we have 5 senses.
Sure.
Well, actually, we have much more than that. And sometimes they become exacerbated when there is a brain control dysregulation or issue tying with fatigue, stress, poor diet, sensitivities to particular triggers, whether it is weather change or postural change, or sometimes very minor details in environment will be, because of these hypersensitivities,
Right.
will be flaring the condition unknowingly from the person, And that is a scary place to be.
I'll bet. And so my friend's reaction, or she doing what she feels she needs to do to get through these episodes of migraines, and they're not very common, once every month or two, maybe even longer between episodes, and then just gone, just not available. Yeah. And is that typical in terms of frequency?
Yes, it is. Yeah.
Okay.
Yeah, it can be totally random.
Okay, so now, we're talking about headaches that can literally incapacitate a grown adult and yes. render them basically pretty useless in terms of being able to mix with society, Sonia. People that call you are at their wits' end. They get their headaches and their migraines are so awful, they literally have to shut their lives down for days on end, don't they?
Yes, yeah. It's a sensitivity to light, to sound, some to smell. Some even have it to where they're nauseous, they're even vomiting,
right.
To the extreme side of things.
Right.
So they're at their wits' end when they do call in.
All right. Well, we need to take a quick break here because we're just getting started, and it's a good time to, because, Philippe, you've sort of brought us to the threshold of, you talked about triggers, and that's what I want to pick up on when we come back. What starts all of this, and then obviously how do we handle it from a therapeutic point of view? Well, our guests are from NeuroKinetics Clinic in Vancouver, in the Highcroft Medical Center building there at 3195 Granville Street, and online at NeuroKinetics.com. Lots more ahead on Boomer Life. Stay with us. We'll be right back.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIAL 650. We're back. This is Boomer Life on CIAL 650.
Welcome back to the program. I'm Sterling Fox, joined in studio by Philippe Souvestre, who is the president and founder of NeuroKinetics Health Services here in Vancouver. Sonia Dheil is the clinic manager and our guest as well on this program. We're talking about migraines. And Philippe, we were talking just before the break about what causes migraines, who are most likely to get migraines, at what point in one's life. Usually in the puberty years, we would see them, but not necessarily. If you don't get migraines, for example, when you're a teenager, doesn't mean that, I'm not going to get them now because I didn't get them when I was a teenager. There are no rules like that when it comes to migraines, are there?
No, not at all. It is a very, in Western medicine, the causation of migraine, as we call that, is not well identified.
We haven't determined the causation of migraines in Western medicine very well?
No.
Okay. So what do we say then when people begin to get migraines? What people tell you, Sonia, when they call you up and they say, look, I've been to Dr. A, Dr. B, Dr. C, and so on, and I have this horrible migraine thing, and nobody seems to either be able to do anything for me or even take me terribly seriously. So what do they tell you that they've been told by other physicians and other practitioners that they've seen?
They've basically been just told to rest.
Right.
Take the, regular off-the-shelf medications that's available in local drugstores.
Right.
And just rest up. Rest well. It'll go away. That's pretty much what they get. And a lot of the time, all I hear from the patients that we have, or former patients that we've had, is a lot of frustration, and they're at their wits' end. They're hopeless. They just need to understand, why are they getting these headaches? Is there a cure for these headaches? And why are they coming, after a few months on a regular basis? Some get them after a few weeks.
Well, let me steal a couple of questions from Sonia here, Dr. Philippe. Why do people get migraines, and is there a cure?
Well, those are complex questions, but I will try to give you a simple answer. There are short and long answers to that. So let's go first with the short answers. So why one would begin to suffer from a migraine?
Yes.
Well, it is my experience that it can be, it is a multifactorial situation that will open a situation to become predisposed to start a migraine condition under given circumstances, which requires a trigger.
Right. And this is what we were talking about just before the break, the trigger. Okay. So Are we all sort of walking around as potential migraine sufferers, just some of us not triggered as easily as others? Is it that simple?
Well, it is there's a gradient of severities in being predisposed to suffer from a migraine.
Okay.
It is my regular observation that thanks to the assessment methodology we have, we found out always that there is at some point in the history of the patient a traumatic experience that has a cascade of consequences leading to predispose that person to migraine spells.
Now, the traumatic event that set up this person for migraines later on, would that traumatic event, Philippe, have been specifically associated with the brain, or would it be just a cathartic event in any person's life?
No, it is my experience that and again, with respect to the type of assessment we provide, which is also includes a very, very strong component, neurophysiological component. The brain controls are always found to be involved in a genesis of a migrainous syndrome.
Interesting.
Yeah.
So there's some wire gets crossed in the brain, and I'm using non-technical language, but I'm not a doctor. You are. But so is it just that? So there's something that's just not right, and that's why you're predisposed. There's something chemically isn't completely in balance or in harmony, and when the trigger occurs, off you go.
It doesn't have to be chemical, actually.
Okay.
Yes, it can be chemical, but it's not always the case. We have seen, for example, cortical exacerbation leading to migrainous attacks, which were not chemical dependent at all, but rather physical.
Okay.
Yeah.
Is there a genetic package? Is this part of something? Is it familial? If grandma got migraines and mom got migraines, am I likely to get them too? Is that part of the deal?
Well, this is what I learned at medical school 35 years ago. Well, my experience has led me to a place where I question that now, because it's not as written in a stone as I have been taught. It may happen. Not everything is possible in physiology. My apologies. Everything is can be seen physiologically, but yes, so we cannot deny part of that can happen as such. But the most of the cases we have been helping wouldn't have responded to the type of treatment we provide if they would have been chemically dependent.
Ah, okay.
That is a proof in the pie.
Oh, okay. Interesting stuff. Sonia, let's talk about people, because we've talked about you as the clinic manager and all the phone calls you take, and you're a very big part of the intake at NeuroKinetics. Walk us through the process. Somebody hears this conversation on the radio and is a migraine sufferer, has had very little satisfaction from conventional medical sources that person has attempted to seek some assistance from. So they go, well, it can't hurt. I haven't received much satisfaction anywhere else, so why don't I give these guys a call? Mm-hmm. So they call you up, you take the call, and walk us through what happens.
Well, they call in, and from there is when I start to list out and weed out what has happened briefly, mm-hmm. to bring them in, to welcome them into our clinic as a complimentary consultation. So they come in, get familiar with Dr. Philippe and the staff that's there, and get to see what we could possibly do for them with a certain condition that they do have.
Okay.
In this case would be migraines, for example. So they come in, we would do that. Then going on forward from there would be the level 1 assessment, which is the brain optimization session assessment.
Okay.
Going on forward to the level 2, then level 3. That after the level 3 is when we go ahead and initiate to do the treatment process from there.
Okay, and
yes.
How long would that process take? For and what is brain optimization? What does that mean? It sounds wonderful, but what exactly does it mean?
It's optimizing your brain is what we really do. Stimulating the brain so it can restore and heal the body and mind.
Okay.
Mm-hmm.
And Philippe, again, with the whole matter of migraines, this is all about the brain. It happens in your brain, and well, with some side effects.
Yes.
Very, very little other places in the body. This is really all about the brain, isn't it?
100%.
Right. So assessment 1 is the brain optimization consultation. And then there's a second session. And what happens at session number 2 of 3?
So what we do is we do a triage of assessments. So the assessments, there is a package of 3 of them.
Right.
Okay. So for 3 of them, we take the data from all 3 of the assessments, the measurable data as we call it, compare the 3 together, and from that point forward, the customized treatment program is made for that certain individual.
I would assume, because you deal with so many people and so many patients who have come to you out of frustration after having received limited, if any, satisfaction from other practitioners, that these people have rather large dossiers of themselves. So, Philippe, when a person comes to NeuroKinetics, is it preferable that they bring as much of that medical history with them as possible?
Yes. This is actually, we ask for that.
Okay.
We always invite potential patients to visit, when they come to visit us at this initial introductory session, to bring as what they have at hand. And in a case they wouldn't have anything at hand, we advise them and we invite them to sign up release authorization so that they allow us and allow other parties to send us their medical records so that we have an overview and an understanding of their past.
So they give you permission to search their medical history.
It is mandatory.
Of course. Okay.
Yeah.
Now, in terms of remedies and cures and all of these magic potions that people come looking for in this instant gratification society we live in, I think probably one of the early assessment sessions is going to allow people to understand that this is not going to be a rapid process. Look at the time they're taking just to find out about me and what's wrong with me. If they're willing to take that much time up front, clearly they're willing to spend a lot of time making me better.
And actually the assessment time is much longer than the treatment times, session-wise.
Really?
Yeah.
Okay.
We spend every assessment, which is a 3-step. The assessment includes 3 steps, as Sonia explained earlier.
Right.
And every step will be between 4 to 5 hours. So it is almost a day we spend together, pacing and following the patient's pace, because sometimes patients are so weak and vulnerable that we have to take our time, which explains the extent of time. So not everyone would be subject to a 5-hour assessment.
Right.
But the fastest pace I have in my experience over the past 3 decades is nevertheless 3.5 hours.
Interesting.
So it's still a significant amount of time.
Sure it is.
And why do we have 3 steps of this assessment? Because we are subject to variability. We go through time, we evolve. Physiology is not static.
Right.
Only 1 step gives us a snapshot. But outside studies have shown through the past decades that a 3-point assessment is sufficient to provide significant data, reliable enough. We don't need 7 assessments, we don't need 2 assessments, we need 3.
And the years of experience have just boiled it down to this is the appropriate way and this is the best way to organize a person into a successful treatment program.
Absolutely. It is a very mature process. Yeah.
Okay. Sonia, I think I've asked you this before, but I think it bears a repeat question. When people come in, particularly for the first time, and some of them, as we've identified, are in considerable distress, do you recommend that they bring someone with them, a family member or a friend or a spouse or someone else?
Yes. They're most welcome to bring along a support system, whether it's a friend, a family member, a relative, anybody that they feel comfortable to sit along with them for the assessment stage. Even through treatment process-wise, actually, during treatments, if they even wanted someone along with them during that process, we encourage that they still have somebody there. We have all our wonderful support staff to sit along with them if they don't want to bring anybody along.
Right.
But it is a great a benefit to them to have somebody that they're comfortable with to sit along with them during that process.
And there's a lot of information, too, to absorb, Philippe.
Yes.
And perhaps a second set of ears is not a bad idea.
It is the point.
Right.
You're absolutely right. The reason is those patients are very tired. It is a role of engagement. They are very tired. They are very fatigable. The short-term memory is always left behind. They are forgetful. And even being in a great shape, it is a little exploit to remember every single thing we have done in a given assessment phase.
Especially ones that goes on for hours, right?
Yes. So for that reason, we encourage, to say the least, we strongly encourage our newcomers visiting us if when they make the decision to proceed for the treatment, assessment first and treatment, if we can help them, is to bring someone they rely, they trust, because that person will be a reference for them to share and remember what has been going on.
Right. And perhaps at key points along the therapy progress, a sort of a reinforcement to don't forget now what they told you at the clinic, and don't forget to do your exercises, or that kind of backup, right?
This is exactly right. This is one of the other points for what reason we do that.
Okay. Bring a friend, bring lots of medical information. Our guest from NeuroKinetics Clinic in Vancouver, by the way, it's right downtown on Granville Street. My gosh, it's in the Highcroft building, right? There's a Granville on 16th, right? That's right. It's 3195 Granville Street, Suite 60. And online, by the way, at NeuroKinetics, NeuroKinetics, NeuroKinetics.com. Have a look while we take the following quick time out.
Canada's only weekly radio show dedicated to the baby boomer lifestyle. This is Boomer Life on CIL 650. We're back. This is Boomer Life on CIL 650.
Welcome back to the program. Joining us from NeuroKinetics Clinic in Vancouver, Philippe Souvestre and Sonia Dheil. We're talking about the brain and what can be done for those who have suffered traumatic brain events. And we're focusing on this particular episode of Boomer Life on migraines. And Dr. Philippe, we were talking a little earlier about the assessment process and how you like patients who come to NeuroKinetics for that first visit, and the brain optimization consultation process to bring along as much medical background and history as they can with them. It's also highly recommended, wherever possible, to bring along a friend or family member. But what happens in the case of someone who's very, very keen to participate and become a patient, but doesn't have that sort of human resource capacity in their life? They don't have a backup person to assist them through this. Is there's anything you can do for a solo flying person? You, former French pilot, you appreciate solo people. How about support services for people who arrive and are intending to go forward basically by themselves?
Yes, mostly with respect to severely incapacitated people, patients. We have designed a position in our team called peer mentor.
A peer mentor,
okay.
Peer
mentor.
Right.
Peer mentor here applies to patients. Peer mentor.
Okay.
So it is a person who is designated to or assigned to a patient coming solo, as you mentioned, and will basically figuratively hold the patient's hand through the process from A to Z, in order to assist and being a second memory backup about all the exchange of data information, which is mutual, and also to answer questions which relates to technicalities relating to administration points, to the assessment, to the treatment, and the evolution. It is not uncommon that patients experience through our treatment, assessment sometimes, but treatment mostly, significant changes which are kind of put them in transiently in a scary place. Even when those changes are good, but they have been brainwashed somehow on nothing could happen to them no longer, even though with the hope of getting better, and this is why they came to see us. So there is a paradox here between what they attempt to reach, which is getting better, is a kind of internal conflict with what they were told by outsiders, such as medical practitioners or other entourage advisors.
Oh, so
and
this goes back to Sonia's point earlier. When they call up, they say, well, I've had numerous encounters with the medical types, and they all said rest. Take pharmaceuticals available at the drugstore and rest. And rest. And that's about it.
Yeah. And I would say it goes beyond the medical. Medical practitioners do the best they can.
Of course.
It is a knowledge, and we all know that. It's a matter of, open-mindedness and mindset, but competency is usual there. The thing is, those people are left alone.
Mm-hmm.
And without any reference. And the only reference they retain is a strong recommendation and statement that nothing else will be able to help them.
Right.
And that is very disturbing, and it begins to conflict when those people experience some changes. So everything what was, all the references they were given go upside down, and they find themselves transiently without any solid reference.
So they're confused.
This is where there's a big confusion.
Yeah.
And there's a big unsettled, they're unsettled.
Even though it's a good confusion, because I was told by I don't know how many doctors that I'm probably never going to get better. The best I can do is manage this. And all of a sudden, I'm in an environment where people say, you can get better.
Yeah, and they get better.
And they do.
And
but
that
because you become accustomed to not, and thinking that I'm never going to get better for so long, getting better is confusing.
And creates anxiety, actually, temporarily.
Right.
So this is why we have this peer mentorship program,
Interesting.
which is a reference, and that person is at hand to answer any further questions that will arise.
Well, as long as we're talking about getting better, and we're talking about migraines in the same sentence, is there such a thing as a cure for migraines, Dr. Philippe?
Well, as a doc, I don't like the word cure because it is very ambitious. Cure means you have got the ultimate goal of being of perfection in all aspects. And I like the word, but it's a dangerous word as far as my discipline is concerned.
Okay.
I prefer to say patient satisfaction with respect to their own goals and objectives, and tying with their lifestyle, their professional performance, personal performance of all kinds. So I would prefer that word, which is more realistic. But of course, cure is a noble word, and we all tend to that in our medical profession.
But okay, not the semantics of the word cure aside, do people actually completely recover from conditions where they were suffering from frequent migraines that were incapacitating? Do people actually get better?
Short answer, most of the patients who come for migraines are migraine-free.
Wow.
Yes.
How do you do that?
Well, we just follow physiology as far as assessment is concerned, and the treatment protocols are designed to, with respect to the assessment data we collect.
Now, you were saying that a migraine typically is a symptom of something greater, and that the migraine was originally set up by some sort of traumatic event in one's life that leads down the road to the migraine condition. So when you try these, or when you enter after the assessment process that Sonia has described for us, once the treatment begins, is that what you try to do? Backtrack to that traumatic event and then sort of mend it out from there?
Well, Sterling, are you ready to come and work with us? You have the right mindset.
So I was just following what you were saying, and it seemed to be the only logical possibility.
It makes total sense.
Okay. So in some cases, that unraveling, I would imagine in some cases, Philippe, the traumatic event in question is not even consciously remembered by some people.
Absolutely. Yeah.
So how do you get to that?
Well, there are different ways. Remembering history happens, may take sometimes a long time, and sometimes people actually remember what happened after the treatment program is over.
Okay.
Because they have recuperated what was missing relating to the cognitive processing underlying their memory circuit, to be figurative a little bit here. And so this is one example.
So it doesn't always follow the same path necessarily.
Yes.
Even though you may try the same method, it produces different results each time.
Absolutely. And this is why the best way to summarize what we do is we follow physiology and enhance it back to restoration.
Right. Sonia, we talked about the likelihood that after the assessment process and the treatment plan has been mapped out, we now have a strategy, we have a game plan. That is not likely going to end after a couple of occasions. It's taken you years to get to this stage in your life. It's taken you quite some time to even find neurokinetics after going around and around and around. So it's probably going to take a while to get through the unraveling process that Philippe just discussed. So typically then, for a person who comes to you with severe migraines, regular severe migraines, how long a process of treatment is it likely to take for that person to reach the point of satisfaction rather than cure, which our doctor friend does not like?
Well, as results are based on per individual, I would say the average treatment program that we would have is about 12 weeks.
Okay.
That's the best way for me to describe it. Like I said, two people together can come in for a migraine. Their individual results do vary. One could probably be done in 10 weeks. The other could be done in 12.
Right.
So approximate would be at least a minimum of 12 weeks, I would say.
Okay, and how many occasions per week, Philippe, during that, say, 12-week session plan that you've organized for that patient?
Okay, first I would like to continue to precise further what Sonia explained very well about these 12 weeks bar.
Okay.
There is a reality, there is a physiological reality, and which is now well understood and emerge in medical mindsets about the stabilization. What is required to stabilize a given condition?
Okay.
It takes 12 weeks, 90 days. You know, as it takes for a little chick, a little egg to form a chick, take 21 days, as everybody knows. Well, to stabilize and restore and stabilize a complex condition which is not limited by the existence of damage, whether in the brain or outside,
right,
that would limit or prevent the full restoration, functional restoration of a complex condition. It takes 12 weeks to restore and stabilize such a condition.
Right.
And that is a minimum.
Right.
So it is, we cannot change that. So our program, as Sonia explains very well, are at least 12 weeks. Most of the time, our patients hit the 12-week bar very successfully.
Right.
Some require a little bit more care. It depends on the complexities. It depends on the fragility of the patient.
Sure.
What has been also given treatment-wise, which needs to be progressively withdrawn, weaned off, and that may also be factors of delay in the process. But 12 weeks is the minimum bar we have.
I'm pleasantly surprised. I thought, given the complexity of the condition and the fact that in many of your patients this has been going on for years, if not decades,
exactly,
that turnaround in 12 weeks is frankly quite remarkable.
Sometimes it's earlier than that, but we need still to stabilize that configuration, that new configuration at 12 weeks. So what happens is the number of stimulations required will be higher at the beginning and will be fading away through those 12 weeks.
Oh, okay. Interesting
stuff.
That
is the pattern.
Let me take a quick break here and we'll come right back. Our guest is the president and founder of NeuroKinetics Health Clinic. Philippe Souvestre is with us, and clinic manager Sonia Dheil is also here from NeuroKinetics Clinic, which is in downtown Vancouver, and the Highcroft Medical Building on Granville Street at 3195 Granville, right there at 16th, just on your way up the hill, heading out of town. We're back with more right after this.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIAL. We're back. This is Boomer Life on CIAL 650.
Back in studio with Philippe Souvestre and Sonia Dheil from NeuroKinetics Clinic in Vancouver. We're talking brain conditions, and specifically today, we're talking about migraines. And one of the things that, Sonia, you've helped us understand is the process at NeuroKinetics Clinic of new patients and the assessment program that you, of course, there is the initial inquiry, and you're good with talking to a lot of people, you and your team speaking to people and and giving them basic information about what it is you might be able to do to help them.
Yes.
But then you need to get them into the clinic and see them and this assessment process. And Philippe, I wanted to ask you about this brain optimization consultation. That's the first of the 3 series of assessment interviews that you've described earlier. But we talked also about triggers and how migraine sufferers are there are certain things that just set them off. And in some cases, your years of experience will validate this, weird light patterns or flashes will trigger a migraine episode in some people. So when you're in the brain optimization consultation process, do you put these people through some of those imaginary triggers to see what works or what will fire off something, or do you just rely on their word? How does that assessment process go?
Okay, this is a very good question because it ties with the principles of what is a migrainous condition as well as what are the paradigms we are using.
Okay.
It is all about threshold of sensitivities
Yes.
that will trigger a migrainous response in given circumstances.
Right.
So to make a long story short, our protocol is a dual protocol. We assess the patient with measuring neurophysiological parameters, which are combined with Oriental medical data and Western medical data,
Okay.
and which are physiology. It's all about physiology here, which are the mechanism of life and behavior and performance, underlying performance. And beside that, we have also ways to stimulate very gently, subliminally, forgive the complexity of the term here, but which means below the threshold of sensing them.
Okay. So you're not bombarding them with strobe lights or any of that sort of thing?
No.
Okay.
No, that would not meet the purpose of understanding what we need to understand.
Well, and plus the fact, and I'm sure the last thing anyone wants is the trigger of an actual migraine episode while undergoing an assessment process.
Exactly, yeah. So we are subliminal, which means we are below the threshold that would trigger a physiological migrainous response.
Okay.
Those patients are extremely sensitive to anything or most of everything. And sometimes they, even after years and years of migrainous problems, some triggers are not well identified.
Right.
It's it's a touchy domain. It's very sensitive.
So is part of the 12-week process of therapy that you were discussing earlier, is part of that addressing those triggers and teaching your brain to reject them?
No, it's not about teaching. It is, I would say, liberating the brain.
Oh, okay.
Yeah. Migraines comes from sensory conflicts, sensory cognitive conflicts, which are now better understood and better identified as well.
Right.
I have been working on migraines for over 30 years with passion, because it is also touching a lot of brain controls which underlie a lot of activities, whether physical, cognitive, which is about perceiving and processing in the brain, but also underlying emotional stability, intellectual performance, and executive performance. So it ties with those mechanisms that underlie brain physiology at work, basically. And from there, we are or we are not in a given condition that would prevent us to achieve what we want to achieve.
Earlier you described your understanding of migraines and how it's changed from your days in France in medical school before you joined the Air Force as a doctor and now. Because now we're talking a few decades here, and you said that your understanding of the entire migraine condition has completely evolved over time. Has Canada caught up to you in terms of your understanding? Does the Western medical practitioner have he or she evolved to the point where you have in terms of the ability to understand migraines in the context of a bigger picture?
Yeah, progress has been made. There is no doubt about that, whether in Western medicine or even in Oriental medicine. So progress has been achieved, and there is still a great need to do better further.
Right.
Definitely.
Sonia, one thing I wanted to ask you about, because we all know someone. Everyone listening right now knows someone who gets migraines. And so we have some degree of understanding as to the awfulness of it, because it's just no fun ever. But what we don't understand is how physically debilitating it can be. And I'm sure some people who arrive at for your assessments after speaking to you on the phone show up and you go, my gosh, what a frail person. They've just been worn down to next to nothing by this condition that's just robbed them of a lot of their physical wellness. Is that the case more often than not, or is it pretty rare? Talk to us about the physical effects of migraines.
It does affect them. Having themselves like going back to the, I believe it was in segment 1 that you were discussing with of one of your friends, going back, cornering themselves in a room in a dark area, isolating themselves from the world.
Yep.
So they come, and it also affects, a lot of patients come in, it affects down to their self-esteem.
Sure.
They come in with low self-esteem because they can't attend, functions. They can't do things with their children when they have these certain things. They can't go to, a different outing, even work. Stats looking back, I know in Canada there's 1 in 4 in household members that suffer from migraines.
Mm-hmm.
There's about 7 million work days that are missed from Canadians on its own. So migraines are quite big. They're huge.
Right.
Yes.
And so, Philippe, when people come to you, are you surprised? I suppose you've been at this a long time, but does it still surprise you how physically worn down some people can get with migraines?
It can be devastating. It has prevented migrainous patients sometimes to accomplish the career of their dream.
Mm-hmm.
It can be very debilitating, and it is also places those patients in zones where they are totally unsure when the next crisis will come up.
Of course.
Mm-hmm.
So they live in a fear of the next crisis.
Sure.
And it is heartbreaking to see.
Right. And so what you can offer in addition to a therapeutic program is hope. The fact that right from that first telephone call, Sonia, people call you up literally at the end of their tether. They've been around the block so many times they've lost track.
Yes.
And they call you up and you're friendly and positive and say, come on down. We'll have a look. We'll have a talk. There is hope. Don't give up yet. Come see us.
There's clarity is what I hear a lot. Thank you for providing the clarity. Thank you for lifting. The burden is gone. They're feeling stress-free. They're feeling someone is there to listen to them, that understands them.
Right. And so with that in mind, Philippe, even though you dislike the word cure, I think in terms of hope, real, legitimate hope, I think that people who are listening to us right now who are either suffering from migraines themselves or, as I said earlier, we all know someone who is, if it doesn't happen to us personally, should probably spread the word that, there is hope. This is not a condition that you have to manage at best for the rest of your earthly days. It can be much better than that.
Yeah, we know very well that what is behind a migrainous crisis or spell is placed in brain. It is a brain manifestation.
Right.
Which can be triggered by sensory stimulation, which will be reaching and far beyond the normal threshold of coping capabilities for a given, states of physical state or
friends, on previous episodes of Boomer Life involving our friends from NeuroKinetics, we've heard from former patients who have said, actually, quote, and this is a direct quote, I just should have gone to see you people in the first place. I would have had a whole lot more fun for a couple of lost years there. And that's generally the situation. NeuroKinetics Clinic, by the way, friends, is in the Highcroft Medical Center building in Vancouver at 3195 Granville Street. And if you want to check them out online, and Sonia's number and Philippe's number and email and all the contact points are on the website at neurokinetics.com. Dr. Philippe and Sonia, lovely to see you again.
Likewise.
We'll come see you again in a month.
It's a pleasure to be here.
All right. We'll see you next time right here on Boomer Life.